Well, good evening, everyone, and thank you for joining us for the Nami-Dane County workshop on My Wellness Compass, kind of navigating a mental health diagnosis. So tonight, your video and audio are off, and if you have any questions or comment that you'd like to make, please put it into the chat. So tonight's workshop will be led by Nora Hill, and I forgot to add, Nora Hill, PhD, Dr. Nora Hill.
Got it, too many degrees.
I
It's
don't know
good.
which,
Work as a PA.
okay, like which honorific do we that you would prefer? Who is a doctor at Edelweiss Behavioral Health here in Madison, Wisconsin. So without further ado, I'll let Nora Hill kind of take it away from here and jump into the content for tonight.
Thank you so much, Quinn. Thank you for having me, everyone. It's a real pleasure to be here. Um, just with the format of my talk, I have some very loose PowerPoint slides, but please feel free, particularly sometimes the anonymity of not having a camera and mic on. I hope open up conversations. So please send questions over. Let's, go on some discussions wherever you'd like to go. I think when different presentations are really led by the audience, I think those lead to the most meaningful experiences for everyone. So I welcome you to do that. And Quinn had so kindly invited me to speak a bit about navigating a mental health diagnosis. And, oh, sorry. When I was just thinking about this, and a lot of times I'll put myself into someone's situation and see like what questions would come up for me, what fears, what just all the different emotions that would come up, and what I would appreciate. And I came up with the ideas of people have different diagnoses, whether it's a mental health diagnosis, even though those are different, but also similar to a physiological illness. But to talk about whatever someone is experiencing and they meet the diagnostic criteria for, so to speak, of they are not their diagnosis. It is not defining for them. They are a human being having a human experience, and part of that experience is X diagnosis. It's something that hopefully people can offer some aid and some treatment so that their day-to-day experience is stable and rich and full of connection and meaning. Um, Depending on how diagnoses are arrived at, discussed, delivered, um, it may not always be someone's first kind of wave of emotions around a diagnosis where they feel quite kind of open and supported and pragmatic. That can be just a really hard spot to be in. Um, and I'd like to offer some very just practical, maybe perspective shifts, tools. And then at any point along the way, as I said, please chime in with questions or, hey, I tried that and I thought that technique was garbage. Let me know. We can troubleshoot. And I always want to know what I'm talking about. Is it valid? Does it land? Too, and where are some situations where it might prove challenging to do, and what could we find an alternative? Um, so that's the general vibe for the discussion tonight. And this goes back to what I talked about before, and a lot of my professional practice and personal one is grounded in Buddhism, not specific as like a specific spiritual practice, but an actually very practical way to interact with the world, especially as the world becomes busier and there's more of everything going around. And it seems like maybe not as much emotional education and support as humans need in these times. So coming back to the idea is that you are not your thoughts. We are human beings who experience thoughts that are created by our brain. But that's it. They don't define who you are. Emotions, similar idea. Emotions are experiences created by thoughts that blend with memory, bring things up that can be very physical and very wonderful and very upsetting. But you are not sadness. You are not hopelessness. You are not even your enthusiasm. You're separate from that. And I began to really learn and understand and practice that, it frees up a lot of space as a human being. So I've always found those really practical, and have the people I've worked with as well. And then again, you are not your diagnosis. You are you. A diagnosis is information. It's not your identity. And then, and going just from this very pragmatic, again, I'm not speaking from like a psychospiritual lens necessarily, but from a pragmatic one of when any of us receive any information, we jump into a story. Humans are wired to think in story and to understand and process experiences in story. And so it makes sense that we attach a lot of things to a diagnosis. And I'll talk about it later, but it could be a diagnosis of high blood pressure or diabetes, bipolar disorder. Some diagnoses are not as stigmatized or triggering as others. Um, but that's the first point where we can learn about ourselves and understand of what kind of stories do we tell ourselves in these situations. And in our situation, uh, having a discussion about a mental health diagnosis, and that can create a lot of confusion and feelings of isolation, of feeling broken, not whole, all those things that are very hard for someone to experience. It's also very understandable of why we go to those places. And with the idea of if we can step back, and there's some circumstances where we're so activated and our emotions have just gone from 0 to 120 in 1 second, that it's very hard to access any kind of tools that we have learned or are learning to help us regulate. Um, and we can move a little bit into that later, and I will. But talking about that, we can observe ourselves. I don't know how many people are familiar with the idea of a wise mind through which we can view ourselves. Um, if it makes a little bit more sense of like perhaps folks have a very kind or wise grandparent that they know, and that could be their version of a wise mind if that lands, or perhaps like a coach or a teacher at school, or a neighbor, or anyone in that space that maybe has lived a little bit longer, has some kind, hopefully calm perspectives, where then from that lens, things can look a little bit different compared to when we as human beings are in a situation that's doing its best to amplify our emotions and kind of derail us a bit. Um, and there's like different parts of us, and that's what I'm talking about, the wise mind. But then the part of us that's telling the story, so to speak, is really our inner critic. It's our ego, formed as a kid, well before we could even remember, as a way to connect and survive in a world. And many people's inner critics or egos are not kind, unfortunately. And we all spend a lot of time trying to unwire those a bit. But for an example, if someone were to receive a diagnosis of a bipolar disorder and immediately were to just have this wash of dread come over them and start going into the story about how they're not enough and they're broken and somehow they deserve this diagnosis and their life is over as they know it. That's the inner critic. That's not really them. It's meant to be protective, but can be really destructive. And then there's the piece kind of in the middle of the two, of wise mind kind of overseeing the whole situation. And then self. Self is the part of us that is kind, that is loving, that says, hey, wait, hey, wait, let's calm down for a second. And it can be very hard to hear that voice because it's more often a whisper, kind of in the face of the inner critic who tends to yell, but it's there. And with essentially all my patients in some form or another, we work together to see how they can begin to listen for and then hear their true self, who they really are, through all the other noise, and use that as an anchor, because then it feels much more realistic to believe and to practice those ideas of I am not my emotions, I am not my thoughts, knowing that you are more. Anything, I just wanted to pause. Is anything coming up here? Does anything seem confusing? Does this land?
So we do have two questions in the chat.
Okay. Can
So
I see it or no?
you can see them if you can click on the chat icon, but I can read them off here for you. So one question is, I've heard Tibetan Buddhist teachers say they don't know where thoughts come from. What do you think, feel, believe about this statement?
About where thoughts come from?
Yes.
Okay. I mean, that's an excellent question. And I honestly don't have like a very sophisticated neurobiologically based response. Um, from my understanding, thoughts, like conscious thoughts, are made up of perhaps kind of a summation or an accumulation of subconscious observations of our environment that we're constantly scanning and trying to filter out what's useful, what's not. And then, and it makes sense to me just from a like more of a philosophical standpoint. But then a scanning of our past experiences as a way to try to make sense of our current reality. And then a thought comes up as the way we make sense of one experience. Does that land? And I'd love to hear your thoughts too, anyone's thoughts.
Yeah, there was another part to that question. It's also saying, in quotes, the mind generates thoughts, end of quote. Seems like a very wasted idea, concept, belief. What are your views on that, Nora? Your views on
And
the
it was that just the
statement?
brain generates thoughts.
Um, that, yeah, the mind generates thoughts.
And I would say too, kind of from this lens again, to me, it makes sense to talk about the brain versus the mind. Meaning the brain leaning into our fear center, our amygdala, our, very, very early human brain that was built to help us survive and to be, aware of any predators and to be able to fight, all that part of us. And then I think about the mind as our human mind. We have a prefrontal cortex. It's a part in the front of our brain, right in our forehead here, that allows for higher order thinking and emotional regulation and gaining perspective. And so that's how I think about the brain versus the mind. But thoughts simply come. I don't think you can train your mind with different styles of meditation to single pointedly focus. And that I would say takes over rather than different kinds of meditation where you allow your thoughts to simply drift by like leaves on a stream. I'm sure some of you have heard. But I would say that thoughts are pieces of information. And then it's our job as humans to decipher if there's meaning or anything worth noticing or using in that thought. Does that help or does that not quite answer the question?
Oh, I think it does. And we got to thank you, Nora. So,
Yeah. I
yeah.
know we went all esoteric metaphysical right away, but
Yeah. You do have a Buddhist and DBT lens as the title. Would you mind just kind of briefly explaining what DBT is?
sure. Thank you. DBT is called dialectical behavioral therapy. And it is essentially, I'm sure some of you have heard of cognitive behavioral therapy. So, kind of understanding our thoughts and actions a bit more, like the why underneath, so that we can learn more about ourselves and hopefully allow ourselves to make some changes if that would improve our experience. DBT takes that, but then adds, and again, not in a religious sense, but adds that like more Zen or Buddhist philosophy of trying to help people understand to delineate that they are not their thoughts. It talks a little bit more about that we have like an ego and a self, and that we don't need to be controlled by our initial impulses or instincts, that we're more than that. But it's cultivating different approaches to being aware and mindful. Like in a stressful situation, it helps people understand why someone else or some other situation might be triggering and bringing up a lot of big emotions. DBT is particularly good in helping people work and understand big emotions so that they don't feel that those big emotions are so destructive. There's many different ways in which emotions can be destructive, and it can help people work with them many times to shift a perspective so that something is not as inflammatory or angering or upsetting because someone's perspective on it has changed. But they also they talk a lot about different ways to help people regulate in the moment of high stress or high activation. And I'll bring like one or two examples in a little bit, which I think are really helpful. But practically speaking, I think as we've all experienced in different ways of when something is incredibly upsetting or we're really afraid or really angry or just overwhelmed, there's not much, self-control that, at least I'll speak because I only have my lived experience, like I can access. And so for me, um, what's the most helpful is really working on that perspective shift and just having some tools to be able to feel in my body how emotions are escalating a bit so that I know earlier before things are just going to, snowball, to take a step back and ground myself or be present, whatever lands for someone. I don't want to be too kind of descriptive there, so that you can approach that situation a bit, refreshed, so to speak, rather than kind of following what seems like an inevitable snowball into emotional dysregulation. Does that does that answer? It doesn't go into like how DBT is taught necessarily, but it is taught very much like a class, like if you were going to learn Spanish. It's very structured, it's very organized, and I think a lot of people appreciate that because then they can also walk away with tools they can try on their own or bring it into sessions with their therapist and kind of finesse those a bit. So it's very practical, which I think most humans appreciate.
Yeah, and it goes back to what you said earlier that, we are not our thoughts. And yeah, that we are not our thoughts. And it kind of gives you extra tools in order to kind of navigate destructive thoughts and thinking. Someone in the chat said DBT is a great treatment modality. So we have some fans of DBT in the crowd here.
Love it. I love it. I always joke, I think DBT, wouldn't it be an amazing world if it was taught in schools for all ages? That would be brilliant.
Yeah.
That would be brilliant. Excellent. I will move on to the next slide. And talking a little bit about like what is a diagnosis of, let's say, bipolar disorder or ADHD or generalized anxiety disorder. Of like why do we even have these very specific terms or language about a set of symptoms? And there's a diagnostic manual called the DSM. I'm sure some folks are familiar with that. There's been different iterations over time as psychiatry has evolved with time. And these different diagnoses provide a common language through which different providers are able to discuss the same condition or the same group of symptoms, really in terms of, if someone is researching a medication or a therapy to help people with generalized anxiety, they want to make sure that their different subject groups are experiencing quite similar symptoms. It's a way to standardize research. And then, two, you want to have a very small and specific set of symptoms if you're pursuing medication trials or, more specific procedures like transcranial magnetic stimulation, for example. So it's to help people be specific about what they're discussing, what kind of symptoms they're discussing, so that many people are trying to help so that they can be the most useful and exacting. Um, and again, that leads into that idea of it offers a standardized diagnostic tool where different diagnoses have a strict set of criteria that people or symptoms need to meet to then qualify to have that diagnosis. And it is helpful as well I think diagnoses can be helpful in many cases so that people don't feel so alone and so confused or frightened about their experience of, you could imagine for like an obsessive compulsive disorder where people have these really haunting, horrible thoughts, and then they feel that they must do a certain behavior or something terrible will happen. It's very generic example there. And that can feel incredibly isolating if someone thinks they're the only human on the planet to ever have experienced something like that. And to hear it talked about, and not only is it discussed, but it's actually a known and well-researched and actually quite well understood disorder. Many people find it freeing. They're not the only one. There even is some like very generic connection, knowing that other people experience these symptoms too. And then it also is tangible in a sense of, okay, there are things that are known about this this diagnosis. And there's hope, there's treatments, there's medications. Like there are things to improve someone's experience. And so I think in many ways they can be very helpful. But it highlights how important the discussion and delivery around a diagnosis is as well. To then in that similar idea of particularly in psychiatry, there's many different kind of iterations on like a flow chart or an algorithm of, okay, someone comes in with OCD and you agree with the diagnosis. Well, what things could we offer to help? Starting perhaps with medication combined with therapy is always huge. but is it something where you want every individual provider to reinvent the wheel or just pick like a favorite medication or something? There's no standardization, there's no like safety profiles, like there's nothing really known or standardized. No. And so having these different disorders and these groups of symptoms that qualify someone to have a diagnosis, again, then standardizes like research that then really helps us create these algorithms that ultimately can offer the most evidence-based effective care for someone. Um, and yes, I think a mental health diagnosis, like a diagnosis as such, and even if you think about it in terms of diabetes or hypothyroidism, like low thyroid, is it helps hone the focus onto where there is something of dis-ease so that we can hopefully offer ease to it. Um, Sometimes I think different diagnoses, and I think particularly in different like pop psychology, like social media, I think sometimes diagnoses can be weaponized, even if it's meant as empowering. It just it feels like it's alienating someone again. So that's those are different platforms or situations I cringe a little bit about because I don't feel like they always are they come across well. But there are some really excellent uh folks like on YouTube who talk about their own experiences with like schizophrenia, for example, that I think are doing incredible work to normalize their experience and to talk about it and share it and so people can learn. And if you know more about someone who, let's say, has schizophrenia and you know them as, I don't know, Frank, the person next door, it's not scary because they're not known because you know who they are too. Um, yeah, those are my general thoughts on diagnoses. Any questions or additional ideas or
Yeah, someone put a
concerns
comment.
in that realm?
Someone put a comment, and you touched on it a little bit. I'll just read the comment. It says diagnoses are great language for clinicians to discuss the diagnosis. However, that same language is weaponized when the diagnosis is particularly stigmatized.
Is there, I understand in general what they're talking about. Is there a particular like question or situation that they're talking about? I could certainly take a guess at a more stigmatized diagnosis. But I love the idea of the discussion.
Yeah, there wasn't one listed, but I mean, we can speak to kind of, that's a lot of what we at NAMI talk about is how mental illness is stigmatized. And they did put a comment saying, no, just the thought as an RN, I hear a lot of them say they are borderline person have their BPD, so borderline personality disorder.
So there's like nursing colleagues who claim that diagnoses as their own.
Or nursing colleagues or patients who claim
Oh.
that they are BPD.
Okay. Or, I think an analogous example would be someone commenting on how they don't like clutter in their house and, oh, that's just my OCD. I think that's probably a similar situation as well. And I think it goes to me as what I was talking about with the diagnoses is I would never want to use language or kind of so perhaps flippantly use a diagnosis that means quite a lot, and it does it. I don't want to minimize that these different diagnoses can carry a lot of weight and cause a lot of distress for a human being. And to me, some of those like flippant one-offs, it feels to me disrespectful to people who do experience symptoms of that disorder. And it also demonstrates a lack of understanding and awareness,
Yeah, and I
which
think
I hope is improved through education, different talks like this.
no, and they clarified. It's like clinicians saying they're complicated or manipulative. Clinicians saying their patients or clients are complicated and manipulative, or they're just borderline. So like kind of touching on what you just said of um, what you just said about it being kind of just a negative comment or kind of grouping things together. Uh,
It's not to, I don't want to like lean on Buddhism too much, but there's this idea of like right thought and right speech and right action. And without, getting into those weeds necessarily, but is that comment useful? Right? Like what is it offering except, a way to like damage another human's being experience or, credibility too. So of no, of course that doesn't land. I think it speaks to a misunderstanding of some mental health diagnoses. I think personality disorders certainly can be quite stigmatizing. Um, but even in, that like a representative situation, it certainly highlights the fact that whomever might say that certainly doesn't understand how someone who ultimately does truly carry a diagnosis of borderline personality disorder, how that developed, right? And I look, it's something that forms when someone is quite young. I won't kind of, dive, way off topic, but it's a tool ultimately that someone developed to survive in whatever childhood situation they were growing up in. And they develop these different behaviors, not purposefully to be manipulative or to be mean or anything like that. It was someone, a small child ultimately, that was fighting to survive and learned behaviors that kept them alive or, in a perceived safe environment too. And so I think looking at like this particular diagnosis from that lens, how could how could anyone who understands that a bit more say something so like easily and you know ultimately like hurtfully about another human being?
um, yeah, yeah, and also there's another like this someone being diagnosed with a bipolar 2 with the bipolar 2. They said they tried a bunch of antipsychotic meds, but none worked, not even Lamictal effective in making them less likely to experience severe depression. And they were re-diagnosed to maybe having major depressive disorder or treatment resistant type. So like, we talk about diagnosis, but how depending on who you're seeing or as time changes, sometimes your diagnosis change. How
Mhm.
do you navigate depending on which doctor you're seeing or as time progressed, like you say, a lot of symptoms show up because that, some things arise because that's how you learn how to take care of yourself as a child. But when it comes to diagnosis, it can impact what kind of diagnosis do you get? How do you navigate that?
I think that's an excellent question. And I think my first thought was, would this, like for this conversation, would the starting place be somewhat like this representative person has been diagnosed? Like, should we go from there where they've been diagnosed with bipolar 2 and then they, work with a psychiatrist or a psychiatry provider and go through these different medication trials, and nothing seems to help their symptoms. And so I think it's after like two failed trials of a medication, someone, may receive the the diagnosis. And I don't think that's a wonderful diagnosis. I'd actually have to look if it's in the DSM, but like treatment resistant or difficult to treat, I have to look if that's in the DSM. I would hope not. um, but in that situation, like if that person came to me and we tried some like reasonable medications or augment strategies, in that situation, I think going back or like stepping back again, wise mind, and saying like maybe we're not treating what we think we're treating. Like maybe we're treating the wrong thing, or we're not understanding all of this person's experience like to the best of our capacity. And so that means going back to the drawing board, and maybe spending more time. And I realize there's different like in different healthcare organizations, some people are, they just are not allowed the time that really would serve someone well to have some of these more lengthy conversations. But going back to the drawing board of, is this the diagnosis? Like, do we really believe that this is a diagnosis, or what other factors could be contributing, whether it's a lifestyle, different external stressors, uh, nutrition, like who knows? Um, and then maybe that shifts a little bit, or like maybe I get stuck and I'm not sure. Then I certainly I'm a big fan of neuropsychologists, and I'll send for diagnostic clarification. So sending to a neuropsychologist who is that doesn't know the patient quite well, but is trained to take very detailed histories and has access to judge much more specific testing than I can offer, that can help tease out some of these subtleties too. And then reviewing the reports from that neuropsychologist with them to discuss, did they uncover a diagnosis that I had not appreciated? Or does it align with what the bipolar 2, for example, and crashing around ideas with this other person for a second opinion too, of what still might be confounding. And then two, I'm very lucky. Edelweiss is incredibly collaborative, of asking your colleagues, like, no one person, can answer everything and know everything, and to be humble enough to throw a case out there and say, hey, what would you do? Or have that person work with that other provider for a little bit and see if they see things differently and something might be useful. Does that make sense? That's how I would approach something that seems to be
Yeah.
stumping us.
No, you gave a lot of good nuggets to kind of approach, or, as a client to approach and kind of digest hearing a lot of different diagnoses and things that we could probably look for from our providers to do, like the possibility of doing additional testing or collaborating with someone else at that clinic in order to make sure that we're getting the right treatment that we need. Somebody in the chat did want to know a little bit more about you, Nora. They said that, you mentioned that you're a PA, and they just wanted a physician assistant, correct? And they just wanted to know kind of what was your area of focus and to help them better understanding what your lens is, where you're coming from.
Sure. Yeah, absolutely. I'm sorry I didn't do that initially. Um, so I went to, gosh, I graduated in 2015 from UW's PA program. It's an excellent program. And physician assistants are trained as generalists. So like a general internist or family practice. And so we don't walk out of school having a specialty, but we have a wider breadth of practice, which is excellent. And I would say The way our schooling is set up, it's probably mm, I'll say like 85 or 90% of the academics of medical school. And then we have 12 months of clinical rotations versus, I believe, maybe a little bit less than 24 months in medical school. And then we don't have residencies. There are some, but they're not obligatory to practice. Um, and so when I first got out of school, I worked in plastic and reconstructive surgery at UW, and that was an incredible experience for so many reasons, but also kind of a stepping stone towards working in psychiatry now. And then I moved into hepatology, so livers at UW, and was there for quite a while, and really, really enjoyed it. And then had a particular interest in alcohol related liver disease. So did a lot of work in a multidisciplinary clinic there with addiction medicine. And that was fantastic. And again, like another stepping stone towards my interest really in psychiatry and psychology. Um, and it was a wonderful experience, but it was very sad and challenging for me when I was really managing a lot of the medical part of their liver issues. But it felt more like pushing, chips around a table rather than actually making any meaningful change related to what maybe had caused their liver disease, such as alcohol use disorder. Um, and so that this just it kind of grew, and I didn't even know what it was until it was there. And then I was lucky enough to be able to transition into psychiatry at Edelweiss, and they're not going to be able to get rid of me. I'm here for life. I absolutely adore my job and my patients, and I'm blessed every day that I can practice in that situation, which allows me the time with patients that they deserve, and I need to offer them the best care I can.
Thank you. And before you move on to the next slide, just kind of because we're on this topic, somebody wrote about, having one diagnosis of treatment resistant depression and then turn around and it's something else that feels shameful diagnosis. Like, how do you have that conversation around shame with your diagnosis with your provider?
And is it related to any mental health diagnosis or like a change in the working diagnosis?
So they listed it was a change. So they discovered something to be they so what they wrote was my treatment resistant depression was later discovered to be something very different, which feels to be very shameful diagnosis that we just learned of last month is DID.
Oh, sure. Okay.
Um, what is
Okay.
DID?
Dissociative identity disorder.
Okay. Yeah. So how do you broker those conversations?
I would say I'm going to couch this a bit with because my practice is set up a bit differently. So I have the luxury of being able to see people for nice chunks of time as they need, and I tend to build really strong relationships with my patients so that I know them over time well, and they know me. And I think that lays the foundation to have a compassionate and useful conversation around a diagnosis or potentially a new diagnosis that maybe seems to explain their symptoms. Perhaps we'll say better for lack of um, a different word right now. Um, but when I'm this would still fall into the bucket of how I would talk about like a borderline personality diagnosis of people who experience symptoms of DID. It's the vast majority of people have experienced trauma, and having these different parts of them that shut down or come forward, so to speak, that makes their behavior perhaps or presentation a little bit different. It's not, malicious or intentional or, even conscious. It's all related to how our brain deals with very upsetting, terrible situations when it feels like it's going to be overloaded with emotions and fear and it cannot handle it. It offers people this ability to dissociate as a protective mechanism, right? Or if I'm talking about like a borderline personality, people develop these different ways of interacting with the world and the beliefs that kind of fit into that diagnosis bucket way back when they were quite small, and it may not arise until they're a little bit later. But if you think about the etiology, or like what is actually going on in someone's brain and experience that manifests as these symptoms are like, wait, they're not, I mean, yes, we need to work with them and help people, but that's like the end of the story almost. I want to know about the very beginning of the story. And if you can talk to someone about their experiences so they can understand a bit more about themselves and how they developed, they're simply learning about themselves more so. And it's not just about a diagnosis, because I certainly could see where that diagnosis could be offered in a manner that is certainly unhelpful, if not distressing too. And I think it comes back to the theme of education. I like to educate patients as much as I can, and the more they know, that also like normalizes. The more you understand about how people develop in general, it it helps these different symptoms and diagnoses make more sense. And it isn't someone's fault. Yes, maybe they have a genetic proclivity towards certain different things, but there's always something that sets something off, so to speak, or actually quite understandable story about how someone developed a different personality process or a way of interacting with the world, or PTSD symptoms too. So that's how I always like rest on things, is talking to people a ton about the why and the how, and not just the end diagnosis. And that seems to be useful. Does that answer the
Yeah.
question?
Yeah, thank you.
Yeah, yeah, absolutely. I'll move on to the next slide. And again, kind of hammering that point home, is that a diagnosis can be useful to guide clinicians so that we can offer tools to a patient to help improve their experience if that's needed. But that's it. I don't think I'll speak for the providers I know in general, and even like in hepatology or different plastics too. Of we never thought about patients coming in as, oh, that's the person with DID, or that's the person who had a double mastectomy, or that's the person who drinks a handle of vodka a day. Like, they were all people first. There were all these other details that were part of their story that were necessary to understand in order to help them. But they're human beings having a human experience, and we all have stories and details. And I think really grounding in that perspective opens up conversations of, connection, particularly with providers. It's what I rest in at the end of the day is the therapeutic relationships I have with patients. I think that offers a lot for both parties, so to speak. And then bring up, play with a little bit with the idea of is someone, I'll use the DID as an example of someone who's uh, been, we'll say, given that diagnosis versus someone who's just been diagnosed with type 2 diabetes. Both can be very upsetting for similar and different reasons. But certainly from at least my perspective, I could understand where like a type 2 diabetes may not seem as stigmatizing, so to speak, because it's talked about a lot more. And in general, the number of people, say in the United States, that percentage it's a much more common diagnosis than DID. Two, but really thinking about like what is this stigma? Like, why? What is the stigma associated with different disorders? And like, where did it come from and why? And at the end of the day, and I can't answer some of these honestly, but stigma is fear-based. It's built out of someone who is not educated or is ill-educated about a disease process, a disorder. Um, and there's just so many examples, and I'm sure you in different capacities have experienced this too, where there's some kind of stigma around some group of people. As humans, we love to do that, unfortunately. Um, and it's completely untrue and founded in like nothing, or in like one very rare event that is not representative of the entire group. Um, and I think, through, NAMI and doing any kind of educational events and people openly talking about things more, that naturally will deflate stigma, because then people with any kind of diagnoses are the people next door, the people at work, the people, wherever you come across them. They're not in this a kind of group set off somewhere that is misunderstood. Anything on that? I don't want to bore you, but I don't want to move too quickly either.
Yeah, there are no comments at this time.
Yeah, just a little bit. We've probably gone over this, so I can go through this, quickly. But again, thinking about what we just did in the last slide a little bit more in terms of why would diabetes be considered perhaps a more acceptable diagnosis than, like I had mentioned, like an OCD diagnosis. I think it really comes down to education. And I would say that the general average person may know less or have not been in contact with someone who experiences symptoms of OCD, but perhaps diabetes feels more familiar. So that's my thought process too. And it's hard even in playing with that idea of wise mind and then self and then inner critic, of the stories we tell ourselves, and even in that the shame bucket and shame spirals too, is are they really things that we believe about ourselves, or are they things that we've been told early on and forward by people we grew up with about ourselves? And then society feels the need to chime in as well, until it feels like that inner critic is ourself, but it's not. Good news there. And two, I think it is worth pointing out of a diagnosis, let's say, of OCD. One person's experience of OCD symptoms is very different from someone else's, as is a lot of times treatment too. So it's not just like a one canned diagnosis. And there's so many variables that affect people's experience and well-being and functionality in different spaces, any kind of diagnosis. To, and I think here I'll pull down to the end too, because it links a lot into that piece about shame in terms of there are so many both physical and mental health diagnoses that are highly heritable, where someone's genetics, they are predetermined. We had no control over our parents, nor did they, to and back and back. And so someone who has a family history of diabetes may be at a higher risk to develop it themselves, though various different interventions may lessen that risk, whether they're intentional or not. And the same thing, for example, with OCD or ADHD. Um, Schizophrenia uh, is quite heritable as well. And so there's so much that's out of one's control. And again, through that piece of education of understanding more about the why and the how underneath a diagnosis, again, it deflates shame because it's not something that's personal or it's not a judgment on someone's character. I think I'll skip these. But it goes through the highlight again of education. I think for any diagnosis, and we can speak broadly in terms of a medical one or a mental health diagnosis, because education is power. That is something I'll stick with for the rest of my life. Um, but then certainly different medications can help both kinds of diagnoses. And of course, there's therapy and building tools to manage diabetes, even though I think that landscape is looking far lighter with GLP-1s more recently. But then skill building in terms of understanding oneself more. So folks have a bit more awareness if different mental health symptoms are coming up so they can reach for tools before things are really, really difficult or they're completely activated to smooth out and to even out their experience and allow it to be more pleasant and functional. And then we're social creatures. We live to connect and have community. And granted, everyone's individual cup is different in terms of its capacity, but having people who you can rely on and count on and feel safe talking to in whatever form they arise, and it may not always be family or even friends, but they all count too. Any questions or thoughts coming up? I don't want to.
Um, not particularly to the someone did ask if you were familiar with a Dr. Gaber Mate or
Oh,
Mott
Gapor Mate.
Gamarmante. There we
Right.
go.
Yeah, I like a lot. I like a lot of his work. He does a lot of work in trauma. He's forget where he's from initially. He's practiced in Canada and was, I believe, an internist, and then really became a trauma specialist. I think there's so much we can understand about people and their experience looking from not only a lens of trauma, and that's such a it can be such a wide definition. I don't necessarily want to veer off into that necessarily, because I think there's a flip side where everything could be traumatic. Like if you look, I think being a human being could be viewed as traumatic, like just the experience of being human. Um, but what I like that Gabor Mate has opened things up to a bit more are the different discussions about our nervous systems and how they respond to different situations, because that's the basis of emotional regulation and awareness. I think that's really the important, I would say, nugget. Like so much interesting stuff that he will talk about. His books are very good too, but in general, looking at the human experience, not necessarily from a trauma lens specifically, but it is included in that, but from an understanding of human beings as walking nervous systems and how our bodies remember different events and emotions and sometimes lock them in as a way to protect themselves from experiencing the pain of different emotions and situations. So yes, he's wonderful, wonderful to read, and I really enjoy a lot of his work. I look at him as a starting place that really just springs more into an understanding of the neurobiology of how humans function and experience the world and emotions. I moved into just some of those dialectical behavioral skills. Just some quite simple ones. I've practiced and taught yoga for quite a while now, and I really love it, and I love how applicable it is to my professional realm as well. And one that, I'm sure everyone has heard about breathing exercises, right? And I would say the simpler, the better. Um, one of my favorites is something quite simple where someone can inhale, maybe for 3 or 4 counts, and then exhale for 5 or 6. So having a much longer exhale than the inhale that will activate our vagus nerve, which is one of the main nerves involved in our rest and digest system. And it will activate that and help us shift from that fight or flight, our amphibian, excuse me, it's back here, our amphibian brain, our amygdala, back into our frontal cortex. We can't, we it's much harder to access, if possible at all, to access our human self, our frontal cortex, our ability to regulate and connect um, when we're in fight or flight. So that's a super simple one. Another really fun one is simply letting your jaw drop, like you're maybe have bitten into an apple, but then are letting your jaw just fall slack. So there's space between your molars and front teeth and lips. That's another very simple but notable signal to your vagus nerve that it's okay to relax. We all hold jaw stress in our jaw and clamp things down, even when we don't realize it. And so that we're constantly in this like, kind of basal level of fight or flight too. And so having just little breaks throughout the day, I have some folks have like reminder alarms that come up to just, back out of whatever they're doing and notice their breath or notice something if feeling the body is not something that at that point is accessible, that's fine. But coming back to some awareness of being a human being. And so that nice inhale and a much longer exhale is wonderful, as well as, spending a minute with your jaw super, super soft. And it can take a while to kind of understand how that feels, because most of us are so clamped all the time. So I just thought I'd throw it's just a few little tools you could tuck in your back pocket as well. And then a lot of times like having that space with that breath to think about the emotions you are experiencing so that you can put a name to them that can make them feel less scary as well. And again, it's without a story. I notice I am feeling angry or I am feeling sad. Good, you noticed it. Like noticing something is the first step in starting to understand it and work with it, heal whatever is needed to be done with that emotion. And without that secondary voice of the inner critic of I shouldn't be feeling this way, or I'm a bad person if I feel angry. We all have different stories in that regard too. But to acknowledge that that inner critic is trying to protect us in some fashion, and it's not helpful now as adults to offering just some very pragmatic awareness of what your experience is like in that moment. And then if it feels appropriate, starting to understand why. Why did that person who cut me off make me so angry? For example, I'm not thinking of any great ideas right now, but you understand. Starting to learn about yourself a bit more. And it'll highlight different situations that it might be useful to know more about ourselves so they don't become so upsetting and activating all the time. Um, and that idea of returning to the present moment, to that idea of being here now, being aware, and just noticing. I think I love that word notice because it doesn't, you know, feel too meditative, which I think has a bunch of could feel quite frustrating, but it's simply to notice. And I don't, when I teach yoga, I don't talk about, oh, you have to notice this specific thing. It's notice that you can't feel your left leg is just as important as noticing that you can feel your left leg. Right. That means you're present. Double thumbs up. And I talk a lot too, and this is again with my patients, how I teach yoga is many times for people, the body isn't accessible, whether there's like a medical reason, someone's like diaphragm may be paralyzed, or they may not have sensation below the waist, for example, um, or parts of their body feel inaccessible due to trauma too, and then breath work could be triggering. There's different scenarios you could think of. So coming at this idea through a trauma-informed lens of a mental secret garden that people can cultivate for themselves. And it really is just imagining a mental landscape. Some people may not be able to think in images, and that's completely fine. You could bring an experience in from your memory however you can. That the visual doesn't necessarily matter, but of a place that you've experienced that feels safe and kind. Sometimes people have not experienced that yet. And so I'll talk about an image that evokes what they think that might feel like, or something that's even neutral too. So definitely not dictating anything, but having this general secret garden that you can cultivate, that I think it's nice to have it stay the same so that you can practice sliding into that in different times when things are stressful and you're starting to notice that that snowball situation is a few steps away, so that you can breathe, relax your jaw, but you're also purposely cultivating a different perspective that then your body will then appreciate. Your body doesn't know that the difference between imagining, seeing something, or experiencing something and the reality of it. So that's fun. Um, that seems to have gone over quite well and seems to land with a lot of folks. Any questions or thoughts there?
No comments at this time.
Right. I'll go through to some of these. I don't want to take too much of your time again. on. But point being, essentially what it's doing is showcasing that there's a lot of very reasonable skills that can be built, even searching through different DBT skills online. Like anyone can, look that up. Again, I pulled in some grounding techniques in terms of one, a good favorite is 5, 4, 3, 2, 1. So if you're starting to feel yourself escalate or get upset in different ways, looking around to see 5 things you can see, 4 things you can feel, 3 things you can hear, 2 smell, and 1 taste. It's a really excellent grounding technique, even if you just do 1 or 2. It certainly can be really helpful. I love this quote by Kristen Neff. She is a wonderful researcher in Austin, Texas. I mean, her whole career has been based on self-compassion, which is amazing. She's amazing. And I love that idea of teaching people how to view themselves kindly and to view themselves as whole because they are. And that having these different experiences that are not pleasant doesn't mean that there's something wrong with them. It's part of the human experience. Sometimes it can be connecting, like for community and peer support, to hear other people's experiences of similar situations as well. But I just love that quote. This is a moment of suffering. Suffering is part of my life. May I be kind to myself in this moment. May I give myself the compassion I need. And then I threw some questions out here. I wasn't specifically sure of the audience or what that, how that would come across. But I would just like to open things up to other thoughts, comments.
Yeah, I love what you have here that a diagnosis can guide care. It's kind of a great thing to remember, especially as, in our own journeys, as we embark on conversations with building our care team and even talking about it with our loved ones, that the diagnosis it can guide care, that it's not who we are. It's just something that we're experiencing. It's kind of a beautiful thing to just remind ourselves of as we're on our healing journeys, whether it be mental health or physical health. It's just a great reminder that it's guiding your care.
Thank you.
Yeah. Well, I want to thank you, Nora, for spending this evening with us.
Thank you.
And
I'm sorry I went over a little bit.
that's a-okay. It's a-okay. So everyone who signed up for my Wellness Compass, will get a email from me later next week, with the YouTube link. You can check out our future workshops and all the programming that we have going on the Nami-Dane County website. Under our Educations tab, we'll list all the current programs that are open to the public. And I'm always looking for ideas. A lot of these workshops are based on what people ask for and the things that are on your mind or that you would like to know more about. So if there's anything that you would love for just to learn more about or to be immersed in community with, please feel free to reach out to me via email or call our office at Nami-Dane County. We would love to hear from you. Um, and unfortunately, we do currently do not offer CPE for peer support certification. That is something we would love to be in a position to do in the future, but not at this time. So I'm going to end the recording.